Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, what's going on in this image here? I'm pretty sure that my future gastroenterologists know what this is. A colonic polyp, right? Yeah. We're going to be discussing this and much more on this presentation on colon pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material. Everything in it helps you succeed to reach your full potential, to do the best that you can on Step 1 and for medical school coursework. And more importantly, it has the foundational material for you to build upon as you navigate throughout your career, whatever it is that you're going into. Now let's start with inflammatory bowel disease. This is chronic recurrent inflammation of the bowel. As we can see here to the right, this high magnification image of a micrograph showing cryptitis in a patient with Crohn's disease. Note, the inflammatory bowel disease likely is occurring as a result of an unusual immunologic reaction to intestinal flora. As depicted in this cartoon here, it's a complex process involving different chemokines and cytokines such as NF-kappa B. Now, the inflammatory bowel disease usually presents as stomach pain and recurrent episodes of bloody diarrhea. Those are the typical symptoms, and it's usually in young women, like from the teens to 30 years of age. IBD is more common in Caucasian societies, Western societies, and particularly Caucasians and Jewish people. Inflammatory bowel disease is subclassified as Crohn's disease or ulcerative colitis. But now let's talk about Hirschsprung disease, okay? This is a disease that results in improper rectus relaxation and distal sigmoid colon peristalsis. In this x-ray, we can see the image from a young patient with Hirschsprung disease. And it shows that the caliber of the descending and sigmoid colon is decreased. There's loss of haustra along with a filling defect corresponding to retained feces. Hirschsprung disease is connected to the syndrome associated with trisomy 21 and increased risk for acute myeloid leukemia, otherwise known as Down syndrome. Hirschsprung disease is due to the ganglion cells' congenital inability to penetrate the myenteric and submucosal plexus, right? And you remember that those ganglion cells are derived from the neural crest. To the right here, we could see the histopathology from a patient that has Hirschsprung disease. Note the aganglionosis. There's aberrant acetylcholine esterase positive fibers in the lamina propria. Regarding Hirschsprung disease, it's between the inner circular and outer longitudinal muscle layers of the muscularis propria, and there is a structure called the myenteric plexus, also known as the Auerbach plexus, and that usually controls motility. The submucosal or Meissner plexus controls blood flow, secretions, and absorption from the submucosa. The clinical characteristics of Hirschsprung disease is based on the blockage of the gastrointestinal tract. There's massive intestinal dilation next to a blockage that could rupture, and that is megacolon. Symptoms also reveal meconium that's not passing and rectal vault emptying during a digital rectal exam. Hirschsprung disease concern requires a rectal suction biopsy. The histology of Hirschsprung disease shows a lack of ganglion cells. Treatment of Hirschsprung disease requires the affected bowel to be removed. So that would be some sort of pediatric gastrointestinal surgeon that's highly specialized. Here we have imaging from an X-ray from a patient with Hirschsprung disease showing anticipated meconium in the intestine, proximal to the colon. And here we have more imaging from a patient with Hirschsprung disease. Note the enlargement from where all the feces is building up. Now let's talk about another common condition that you'll have to know about called colonic diverticula. Colonic diverticula are mucosal and submucosal outpouchings through the muscularis propria. They are actually false diverticulum. Colonic diverticula are associated with colonic wall stress, all right? And this usually occurs in the elderly population. Risk factors of colonic diverticula include constipation, straining with bowel movements, low fiber diets, and older age. Colonic diverticula most often affects the sigmoid colon, right? That's the most typical place for this to occur. Colonic diverticula usually develop where the vasa recta crosses the muscularis propria. So this is the weak area in the intestinal wall. Colonic diverticula are usually asymptomatic, right? No big deal, no problem, no problemo. But complications of colonic diverticula include rectal bleeding, known as hematochezia, diverticulitis caused by the obstruction from feces that has symptoms resembling appendicitis in the left lower quadrant, diverticulum with a fistula that becomes inflamed and could rupture and adhere to neighboring structures, right? That's bad. As well as a colovesicular fistula, right? And these fistulas can actually show urine with air or stool in them, right? Yeah, urine with air or stool in it. That would be a sign of a colovesicular fistula. And here we have gross pathology from a large bowel that was surgically removed, showcasing colonic diverticula, right? Note the diverticula appear on either side of the longitudinal muscle bundle. Now let's talk about another common condition known as angiodysplasia. Angiodysplasia is mucosal and submucosal papillary beds anomaly, okay? Here on this endoscopy, we can see angiodysplasia. Angiodysplasia typically develops in the right colon and cecum as a result of strong wall strain. Hematochezia is a typical sign of angiodysplasia, rupture in an older adult. As you can see here on this imaging showing multiple round angiodysplasias being observed, as well as the bleeding that occurred from them, right? Now, this is a very important topic to be aware of. Hereditary hemorrhagic telangiectasias. Hereditary hemorrhagic telangiectasia is a thin-walled blood vessel as a result of an autosomal dominant disease. They are particularly prevalent in the mouth and the gastrointestinal tract. And while we're talking about telangiectasias, where else have you seen that? I'll give you a clue. With Crest syndrome, right? You remember that. You've heard of Crest syndrome with the calcinosis and Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia, right? So when you see telangiectasias, you should have CREST syndrome on your differential, as well as hereditary hemorrhagic telangiectasias, okay? You got it? All right. So hereditary hemorrhagic telangiectasia frequently presents on the oral mucosa, right? It's a lot easier to see than the gastrointestinal tract clinically, right? Makes sense. Here we have more imaging of hereditary hemorrhagic telangiectasia, and note, it's associated with an eponym known as Osler-Weber-Rendow, right? So it's also known as Osler-Weber-Rendow syndrome. Hereditary hemorrhagic telangiectasia may present as vascular malformations on the liver in a patient, like we can see on the CT scan. Now, we know that hereditary hemorrhagic telangiectasia is inherited how? Autosomal dominantly, right? And we can see that inheritance pattern here to the right depicted in the cartoon. Now, this inheritance pattern pretty much applies to autosomal dominant conditions in general. Now let's talk about ischemic colitis. What is that exactly? Well, ischemic colitis is inflammation of the colon due to ischemia. Ischemic colitis is more often not to happen. It's more likely to happen in the watershed area, such as the splenic flexure or the area of the superior mesenteric artery, right? The most frequent cause of ischemic colitis is superior mesenteric artery atherosclerosis, right? Ischemic colitis symptoms include postprandial pain, weight loss, pain in general in the abdominal region, and bloody diarrhea. Here we can see imaging obtained through some sort of scope showing ischemic colitis. Note the upper portion that's somewhat gray, that's the ischemic area, whereas the bottom area that's, pink, that is the area that has not been affected by the ischemic colitis as of yet. Now, what's irritable bowel syndrome? Well, let's talk about it for a bit. We know that some symptoms of irritable bowel syndrome includes recurrent stomach pain, bloating, excessive gas with flatulence, diarrhea, and constipation, right? Irritable bowel syndrome is typically experienced by middle-aged women. Irritable bowel syndrome is typically connected to abnormal intestinal motility. There's no obvious pathogenic alterations that are noted in IBS, but dietary fiber intake may help symptoms of IBS. Now, what are colonic polyps? Well, colonic polyps are colonic mucosal protrusions that are raised, right? Polypoid. As we can see here in this microscopic image depicting an H&E stain from a patient that had a colonic polyp. Note that this one was hyperplastic. Adenomatous and hyperplastic polyps are the most prevalent forms of colonic polyps. The overgrowth of glands results in hyperplastic polyps. Histologically, colonic polyps typically appear as polypoid or hyperplastic or sessile serrated, tubular, villous like fronds, or tubulovillous, a combination of tubular and villous. To the right, we can see a depiction of a classical traditional serrated adenoma. Now, keep in mind that polyps may proceed through the adenoma-carcinoma sequence to adenocarcinoma. To the right here, we have the microscopic depiction of a villous adenoma. Note the large glands containing enlarged cells with hypochromatic nuclei. Now, this is important to note. These colonic polyps in general can be benign, and some of them, like the hyperplastic ones, are benign and incapable of becoming cancerous. But the neoplastic gland proliferation results in adenomatous polyps. And adenomatous polyps are the second most typical kind of colonic polyp. And adenomatous polyps are benign, but pre-malignant. Adenomatous polyps may proceed through the adenoma-carcinoma sequence to carcinoma. The molecular transition from healthy colonic mucosa to adenomatous polyp to carcinoma is described by the term adenoma-carcinoma sequence. You will see that. Adenomatous polyposis coli, or APC, gene alterations, whether sporadic or germline, enhance the chance of polyp development. Polyp development is caused by the APC gene mutation. Aspirin may prevent progression from adenoma to carcinoma. P53, that's important to note, P53 mutation and increased cyclooxygenase expression allow for the carcinoma to develop. Colonoscopy and tests for fecal occult blood are used to check for polyps, right? We know about that. We know about screening, right? That's the whole purpose. The polyps are typically clinically quiet, but can bleed. Prior to adenomatous polyps developing into cancer, removal is the goal. Adenomatous and hyperplastic polyps have the same appearance during a colonoscopy, right? So we need to see these microscopically. As a result, all polyps are removed and analyzed under a microscope, as we can see here to the right of a sessile serrated adenoma. The biggest risk factors for turning an adenoma into a carcinoma include the polyp size, right? Is it greater than 2 centimeters? As well as the growth rate, right? Is it growing fast? It might be cancerous. Does it have villus histology? We don't like that. That's a bit complex, right? All risk factors for it from changing from an adenoma to a carcinoma. Now, to the right here, that's adenocarcinoma, right? Note how basophilic and unorganized it looks. And in regards to colonic polyps, we can see here on a scope image a colonic polyp with a short stalk here. And here we can see microscopy from a hyperplastic polyp. And here we can see a tubular adenoma as an incidental finding from a colectomy specimen that was removed. And here we see various depictions from scopes with corresponding biopsies. Now, normally I would not like to read this, right? You know how to read, you're smart, but it's important for you to know these differences. So I'm going to do you the solid and make sure you got this, okay? Because I want to see you win, right? If it wasn't important, I wouldn't go over this, but this is very important for testing purposes and for future medicine purposes. So let's go through this here. I know it's a lot of text, but we got this. I'm going to point out what you need to know. So if you pay attention to the image, you'll see about 12 depictions of scope images, right? And you'll see 12 corresponding images of histology beneath each scope image, okay? You see that? Right, big picture. Start with the forest before we get down to the trees. So in top left, we see A, right? And its corresponding histology is below it. And then we see C with its histology below it, etc. It goes on like that. All the histology is for the corresponding scope image that's above it, okay? Makes sense? Right. So for A, wow, doesn't that look clean, right? Gastrointestinal specialists everywhere are praying for the day when they scope their patients and it looks this normal, right? And you can see the associated histology below it showing classical colonic crypts, right? No lesions, right? It's not excessively distorted, no excessive basophilic staining, right? It's normal. A and B are classically normal. Let that sink in. Let it burn into your skull. Now look at C. Do you see any polyps there? No, right? Looks clean, looks normal, right? Look at the corresponding histology for C, which is directly below it, and D. Do you see excessive basophilic areas? No. Do you see any abnormal glands? No. Do you see any weird fronds? No. This is normal, right? A is normal. C is normal. The corresponding histology for A and B is normal. The corresponding histology for C, which is D, is normal. You have to know normal before you know abnormal. Speaking of which, look at C. Does that look clean and smooth? No, you see polyps. And in G, do you see polyps all the way in the right top corner? Right. Clearly there are polyps. Let's keep going through the scopes. Back to the left side. You see I there? You see those polyps? Yeah. And K, do you see a big polyp down at the bottom of it? Yeah. And M, do you see a big polyp to the left there? Yeah. And O, do you see a whole bunch of polyps? Yeah. And Q, back to the left on the bottom, do you see a bunch of polyps? Yeah. Right. Sure. S is a bit tricky. U, do you see a bunch of polyps? Yeah. W, do you see a bunch of polyps? Bit tricky. So let's focus on S. Look at its histology. Does that look normal? No. Why does it not look normal? We don't see a bunch of clear glands, right? We don't see a bunch of niceness. By niceness, I mean there's symmetry, there's goblet cells or the tube-like structures. We don't see that. It looks a bit basophilic and frond-like. Now, what about W? Right? That one's looking smooth, right, in the scope. But what about its corresponding histology? Looks a bit different, right? That's because in W, there are low-grade intraepithelial lesions, right? So you can see that more so microscopically. That's low-grade intraepithelial lesion, right? So that one's a bit tricky. And what about S? Well, it looks a bit smooth, but below it, you can see that it's clearly some sort of pathology occurring. That's another intraepithelial lesion, right? So of these, right, big picture, S is weird, W is weird. You need the microscopy to figure that out. All the other scopes show lesions except for A and C, right? Some of these lesions are just polypoid. Others of these lesions are, cancerous. Like, for example, where would we see some cancer? Perhaps E, right? So it's histology in F, right? So the big takeaways. This is why we do screening. All you future gastroenterologists out there, you future pathologists, specifically gastropathologists or GI pathologists, you're going to be seeing this daily, okay? And everyone else, you're going to be referring your patients to get screening, right? And you need to be aware of this now and in the future, right? Now because it's easy to test, and in the future because we want to make sure we're supporting our patients. Now let's talk about this commonly tested entity, familial adenomatous polyposis. With this condition, there are numerous adenomatous colonic polyps characterized, right, by this autosomal dominant disease. To the right here, we can see imaging from a sigmoidoscopy of a patient with familial adenomatous polyposis with innumerable polyps. Can you see those polyps? How many polyps are there? You want to count that? No. Just say innumerable. If I had to guess, though, just in this image alone, that's a lot. 10, 20, 30, 40, 50, 60, 70, 80, 90. At least 100 in this image. Let's just say innumerable. Now, familial adenomatous polyposis occurs due to a hereditary APC gene mutation on chromosome 5. Yes, you have to know those mutations, and yes, you need to know that chromosome. There's another lesion associated with chromosome 5, right? Is that Cruda shot, right? With the cat-like face or something like that, the cat-like sound? Is that a thing? Let me know. Figure out a way to let me know. See, we educate each other, right? Help me out. I'm helping you out. Now, what is this? APC gene mutation increases the likelihood that adenomatous polyps may form in the colon and the rectum, right? Familial adenomatous polyposis patients may require prophylactic colon and rectum removal. Almost all patients with familial adenomatous polyposis will acquire cancer by the age of 40 years old. Hence the prophylactic removal of large portions of their gastrointestinal tract. A non-neoplastic proliferation of fibroblasts is known as fibromatosis. And this develops in the desmoid type in the retroperitoneum and kills the tissue there, right? The desmoid type is highly aggressive. An osteoma is a benign bone tumor that typically develops in the skulls, and it can be associated with familial adenomatous polyposis in particular conditions. Familial adenomatous polyposis with fibromatosis and osteomas is known as Gardner syndrome, which will likely show up because it combines a lot of pathologies with a classical lesion, right? So be on the lookout for this. Familial adenomatous polyposis with central nervous system malignancies, such as a medulloblastoma or glial tumors, will likely show up as well, right? And that is called Turcotte syndrome. You could think of this as a medulloblastoma with familial adenomatous polyposis. So don't forget the Turcotte syndrome. And here we have a micrograph of tubular adenoma from a patient that had colorectal cancer, right? You can see them kind of next to each other. Now let's talk about juvenile polyps. Juvenile polyps can be sporadic, right? They could be benign hematomatous polyps that appear in young children, right? And they commonly manifest as a single rectal polyp that prolapses and bleeds. Multiple juvenile polyps in the colon and stomach are a defining feature of juvenile polyposis. The likelihood that juvenile polyps may develop into cancer is increased by their abundance, right? So the more polyps present, the more likely cancer is to develop. Now it's important to have different mechanisms of pathology when you see a polyp, right? Because there's a broad differential. For example, we have a juvenile polyp, right? But also on the differential, you need to make sure that you rule out Mentionnaires disease, right? Which classically shows with foveolar hyperplasia. And you also need to rule out Peutz-Jeghers polyps, right? Which also show up as foveolar hyperplasia with cystically dilated glands, right? So as future pathologists that are out there, have this on your differential. But for testing purposes at your current level, it's highly unlikely that you'll have to differentiate these microscopically. But be aware of juvenile polyps and Peutz-Jeghers polyps. So to make sure we hit that home, you can see here a giant juvenile polyp in A and the corresponding histology for showing a juvenile polyp with that expanded lamina propria and the dilated crypts that are associated with this particular lesion. Note that at times they may be inflamed, marked by that inset in the top right for the histology. Now you're going to need to know Peutz-Jeghers syndrome. And this syndrome is characterized by hamartomatous polyps, as well as skin lesions. What skin lesions? Well, freckle-like lesions on the mucosal surfaces. So they can be on the lips, the oral mucosa, and even the vaginal skin. To the right here, we can see characteristic lesions associated with Peutz-Jeghers syndrome, such as freckle-like lesions on the mouth, hand hyperpigmentation, right? As well as pigmentation of the buccal mucosa, right? So be on the lookout for those freckle-like lesions. You future dermatologists out there, help us that are going into clinical roles that aren't derm by identifying these lesions. Put it in your note. When they go to GI, they'll say, huh, and they can corroborate that information. It's nice when all the pieces line up and the patient can actually be diagnosed with Peutz-Jeghers syndrome. Remember, Peutz-Jeghers syndrome is autosomal dominant, and there is an increased risk for gynecologic, breast, and colorectal cancer in patients with Peutz-Jeghers syndrome. Here we have imaging. I haven't forgot about you, future radiologists. I know you love seeing imaging. Here you go. This is a barium enema radiograph showing multiple polyps. Can you see the polyps in there? I'm a pathologist, right? I'm going to defer to you and radiology on this, but if you are able to see this, then you probably see that large. Oh, I see it now. I see it. Do you see it? Do you see the large pedunculated lesions? Right? I see it. When you see it, you can't unsee it. Maybe I should have went into radiology. Anyhow, let's talk about colorectal carcinoma. Colorectal carcinoma is cancer that develops in the rectal or colon mucosa. As seen here to the right, look at this gritty debris. Look how basophilic and unorganized it looks, right? That dirty necrosis. Colorectal carcinoma is the third most frequent cause for cancer and the third most frequent reason for cancer-related fatalities. You don't hear that word fatality much, do you? I remember it from playing Mortal Kombat. What if that was a finishing move? And then like Scorpion or Sub-Zero gave someone colorectal cancer. Now, the incidence of colorectal carcinoma peaks between the ages of 60 and 70 years old. Colorectal carcinoma most frequently results from the adenoma carcinoma sequence. Microsatellite instability is a second significant molecular route. Remember that mismatch repair, right? The microsatellite instabilities, right? You remember that? Microsatellites are non-coding DNA repeating sequences whose stability is preserved throughout cell division. But the instability suggests flawed DNA copying processes. For example, the DNA mismatch repair enzymes are messing up. Hereditary mutations in DNA mismatch repair enzymes are the cause of hereditary non-polyposis colorectal cancer, right? You remember that. You know that. In hereditary non-polyposis colorectal cancer, there is increased risk of ovarian, endometrial, and colorectal cancer, right? So remember that. At a relatively young age, colorectal cancer develops spontaneously, not from any sort of adenomatous polyp. And this is typically right-sided. And be aware that at the age of 45, as of now, at the age of 45, fecal occult blood tests and endoscopy are used for colorectal cancer screening. And just, for completion, this is a recent change, right? Prior to 2024, it used to be 50 years of age, but it's now 45 years of age. The objective is early cancer detection and removal of the adenomatous polyps before a carcinoma can develop, right? Colorectal carcinoma can occur anywhere along the colon's length. And symptoms of left-sided colorectal carcinoma include decreased stool volume, pain in the left lower quadrant, blood-streaked stool, and a napkin ring lesion. Symptoms of right-sided colorectal carcinoma include iron deficiency anemia secondary to the occult bleeding and abdominal discomfort. Now, it's important to keep colorectal carcinoma on the differential for a patient with iron deficiency anemia, right? Streptococcus bovis endocarditis has the propensity to affect people that have colorectal carcinoma, right? And the stages describes how far the lesion has gone for colorectal carcinoma. So T for the tumor, for the depth of invasion particular, N for the lymph nodes that the cancer has migrated to, and M for specific metastasis, like where the tumor has moved to, like other adjacent structures or organs. And due to the absence of lymphatics in the mucosa, colorectal cancers, those tumors that are restricted to the mucosa, typically do not disseminate. But metastatic colon cancer commonly involves the lungs and the liver, right? So the liver and the lungs are common sites of metastasis of colon cancer. And there's a serum tumor marker called carcinoembryonic antigen, or CEA, that is helpful for evaluating the treatment efficacy and spotting recurrence of colorectal carcinoma. Carcinoembryonic antigen is not useful for colorectal carcinoma screening, right? So we need to rely on our gastroenterologists doing their scopes to make sure that they biopsy those polyps, that they get a good look in there, okay? At age 45, starting then. And with that, we just completed another lecture. We're making great strides to ensure you do your best on step 1 and on your coursework. I hope these are all just great for you and that you're soaking up all the knowledge, okay? I'm rooting for you. You're going to do great. Keep making me proud. Keep asking questions. Any question, comment, or concern that you have, let me know. And keep doing what you're doing. You're on the right track. I'll talk to you later. Bye-bye.